Good morning, everybody. It's a pleasure for ELPA welcoming Dr. Maja Sofie Thiele today. Dr. Thiele is a medical doctor, clinical scientist, and associate professor at Odense University Hospital in Denmark. Research focuses on non-invasive tests, both for diagnostic and prognostic purposes, but also for population-based screening and risk stratification to optimize referral pathways for primary to secondary care. She has a special interest in alcohol-related liver disease and has published several papers on imaging and serum biomarkers to detect early alcohol-related fibrosis and steatosis. Welcome again. It's a pleasure.
Thank you so much.
It's a pleasure to welcome you today. Professor Thiele is also the leader of the work package number 2 in the framework of the Liver Screen project. The work package 2 has the title Population-Based Screening Study. So before entering into the details of your involvement in the work package 2 as a leader of a team, I would like to start asking you something more generic regarding the Liver Screen project. If you open the website and you browse a bit the website, the first, let's say, shocking information you can find is that the project aims to set up a screening program for detection of liver fibrosis, and the aim is screening 30,000 people in different European countries.
Exactly right. Yeah.
Quite.
It's quite a number. Yeah.
Quite a number.
I know.
Yeah.
But I think, well, the number is what the number is, and I agree. It's a huge number of people, but I think this is also a very ambitious project. And we have this technology that we in the liver community have known now for a decade, the transient elastography or liver stiffness measurement. And we have used it on the populations that we as hepatologists see in our everyday life in the liver clinic. And the ambition now is to kind of take it out and broaden it out towards the whole, in the first step, the whole European population. For the European population to benefit from this technique that, honestly, me as a clinical scientist, it has been revolutionizing our work and our ability to detect a liver disease at a far earlier stage than we could just 10 or 15 years ago. So when we do population-based screening, we need a lot of patients because the prevalence of advanced fibrosis and cirrhosis in the general population is not in the 10s or 20%. It's more like 1 or 2, 3%. So to be able to detect a sufficient amount of people with kind of this hidden liver disease going about their lives, but with a liver that are just year by year getting more fibrotic, to be able to detect these patients, we need the large number, the 30,000 patients, at least for us to do a study that has actual clinical implications and can be implemented in clinical care in the future.
These 30,000 people are recruited among risk groups in the general population, or is more random general population? Was a curiosity.
No, it's a very good question. It's random population screening, the 30,000. So we do not select on any risk factors, but we are very anxious about the risk factors, because obviously we know that certain risk factors increases the risk for liver disease substantially. That is excessive use of alcohol, it is obesity, type 2 diabetes or pre-diabetes, other types of metabolic disease, dyslipidemia, etc. So we are very aware that these kind of risk factors exist in the population. However, not all patients are aware of it. And there's also a stigma towards liver disease that maybe makes it more difficult for those with risk factors who perhaps in the back of their mind, they do know that they are at risk, or that their liver are at risk, or they don't know. But anyway, the stigma may hinder these people, seeking out their general practitioner, seeking out a screening program. Whereas if you do offer screening to everyone, then my just personal opinion is that we may be able to catch some of those who would not enter into a risk factor specific screening program. But we don't know. That's a part of the project, is also, of course, registering these risk factors and looking at whether there's an extra effect of screening specific groups.
Before entering into details of the work package 2, I have the last question, always out of my curiosity. I watched a very nice video regarding the project, very well explained, and I would like to know more about this screening tool that basically is new compared to the invasive technique that there used to be on the field.
So yeah, so liver stiffness measurement or transient elastography is an ultrasound-based technique. So it doesn't use radiation. It's totally non-invasive, and very importantly, it's point of care. You get the results after a 5 or 10 minutes examination. So in that sense, it's really a nice technique for getting accurate results and accurate information about the health of a liver in a non-invasive way and with a point of care technique. So it basically sends in waves into the liver, makes the liver vibrate a little bit. And then if you have a soft liver, your liver will vibrate slowly. If you have a stiff liver, the liver will vibrate more rapidly, or the vibrations will be faster in the liver. And what the equipment does is it kind of measures the velocity of these vibrations. It's called shear waves. So by measuring how quickly your liver vibrates, you get an idea of how stiff the liver is. That's basically it.
That's amazing. So finally, we can really enter into your work in the framework of the project. What's a population-based screening study, and what's your daily, let's say, which are your daily activities in as a leader of the work package? What do you do basically?
Oh, thank you. I unfortunately I don't have so much hands-on, but I come from a background of clinical hepatology and clinical research, so I really enjoy having to do with patients and people. But unfortunately, I have less and less of the kind of the hands-on. But now I have a team here in Odense. It's research nurses. We also employ medical students. We have even an engineer to keep track of all the data. And our main task beyond just screening many thousand people, Danish people from the Funen area. Besides screening those people, we also manage and host the database that we use to collect all the data, not just from Denmark, but from Spain and France and Germany, Italy, all over Europe. All the liver screen partners, they enter the data into this data hub that we in Odense host. So we also spend a lot of energy managing the data, of course, with a very close collaboration with the coordinator in Barcelona, where the clinical trial unit is, and they keep track of all the quality of the data. We just kind of do the do the work in the engineering room of the data. But we send out invitations. We take calls from people who want to participate. We have 2 study rooms working in parallel with 2 of these fibroscanners that for using the transient elastography. We do blood sampling, we do biobanking. So we see around our maximum capacity is, I think, 60 participants per week. Sometimes it's fewer. In the COVID times, it was even fewer, but we managed to keep just a small number of people coming through.
That's great. So the very, very last, because I'm curious, of course. And the more you speak, the more curious I am. You are basically among and in between different research center and all the different partners of the project, because you receive data from the other countries participating into the project. I had a look, and I think that LiveScreen is the scientific medical project ELPA is involved in with the highest number of partners. How is it?
It's great because fun. It's fun. It's great fun. I mean, I'm a true European. I love European collaborations. And I think this has been the worst about COVID lockdown, that we have not been able to meet and interact and learn from the others, because what keeps amazing me is how different our healthcare systems work. They all kind of manage, but it's on completely different ways. And in that sense, I think having many partners from Southern Europe, from Eastern Europe, from the north of Europe, as we are, is really important for our results to be generalizable. Because if we only did this in Scandinavia, we would only have a screening program suited for the Scandinavian healthcare system. And it's impressing the way these different European healthcare systems work. And I think it's a huge enjoyment to be able to participate with skilled researchers and skilled clinicians from across Europe.
Thank you very much. Thank you for being here with HELPA today.
Thank you.